So welcome to this session on structural changes in the shoulder. My name is Birgit Juul-Kristensen. I'm from the University of Southern Denmark, associate professor there. And I'm going to chair this session together with my colleague, Kim Ingwersen from Vejle Hospital. Numerous results on other joints have already shown that there's no clear relationship between the structural pathology and PROMs. However, only few studies have looked at the shoulder. So the aim of this session is to present an overview of image-detected structural changes in the shoulder, their association to shoulder pain and function, and also some potential implications for exercise therapy. We have 3 presenters, and they have been given 25 minutes each. So we totally have 90 minutes. So there should be some time to discussion afterwards. We will have a short questions after each presentation, and then we will try to make a general discussion and bring in all your experience from clinical practice there. I will start by saying or talking about image-detected shoulder structures and the relation to self-reported pain and function. And then we will have Karen McCreesh from the University of Limerick, who will talk about a short-term effect of fatigue and the loading on the supraspinatus tendon thickness. And then afterwards, we will have Kim Ingwersen talking about longitudinal effect of exercise modalities on also the supraspinatus tendon thickness. Also, before going on to the shoulder, and actually in line with this knowledge already known, I would like to draw your attention to a presentation that took part this morning on structural changes in the Achilles tendon after 6 weeks of rehearsal in ballet dancers to the Swansea. So the title of my presentation, as I said, are image-detected shoulder structures related to self-reported pain and function. A little bit of the introduction. Shoulder pain is common, as we know. Recovery of the shoulder problem may be slow. We also know that the economic burden is high and that imaging is often used as a clinical aid in shoulder diagnosis, as it detects more accurately than clinical examination. However, the association between these imaging features and PROM is still unclear. Some of you may know that there's been a recent review on this area from a group in England by Tran last year, 2018. It is the first systematic review that examines the association of imaging features and common shoulder symptoms. I will briefly summarize the results, and I will also supply with some of our own results from a recent review we performed. However, to start with the poorest or the bad thing is that I would like to give you to set this review into perspectives, as there are some limitations with it. This review is a very broad search. The populations included are very heterogeneous. They did not perform a sensitivity analysis on age, and they did not perform a meta-analysis, only a narrative analysis of the evidence. However, the strengths are, it's the first systematic review, it's the last one, and it gives a good overview and some good tables describing the studies. It also performs a quality assessment of the studies included with a 20-point checklist, which has previously been used in OI studies. It is not a standardized quality assessment, but it's very relevant. And the review presents results from both low and high quality studies. However, they only conclude on high quality studies. And to be included as a high quality study, you need to have an individual score which is above the group mean. As I said, it's a very broad systematic review and covers a lot of shoulder conditions. I have taken the liberty to concentrate on the conditions that I found would be most relevant for this audience. As I said, I will also report on some of our own results from a recent review, and I would really like you not to take photos, please, because it has not been published yet. But I will come back to that. The inclusion criteria of this population in the review was, of course, that there should be some kind of structural abnormalities on imaging, different kinds of imaging, and there should be reports on shoulder symptoms. They used all the general large databases. So first, to look at rotator cuff tears and tear size. They found in 4 ultrasound studies, 3 MRI studies, and 1 scintigraphy studies of low quality that there was an association between pain and the size of the tear, of the rotator cuff tears. However, there were also 1 ultrasound study, 2 MRI, and 1 combined X-ray and ultrasound study of high quality that did not find this association. Regarding disability, there were some studies, 4 studies of high quality that found an association, but also, again, no association in 6 MRI studies and 3 ultrasound studies. Of note is that there was only one of those MRI studies that were well adjusted by age and sex. So they conclude that this one study that was well adjusted did not find any association between tears and tear size in relation to pain and disability, and the remaining studies had conflicting findings, and they were of mixed quality and unadjusted. Regarding tendinopathy, again, there were some studies, 1 study, ultrasound study, with a mixed population of RC, rotator cuff tears, and tendinopathy that found an association to pain, and that was a high-quality study. But again, there was another study also of high quality that did not find this association. Regarding disability, 1 study of ultrasound, a high-quality study, found an association, and 2 other studies, also high quality, did not find this association. Regarding symptoms and function in relation to tendon thickness, there was 1 of high and 1 of low quality that found an association. But again, there were other studies that did not find associations. So they conclude that there were conflicting associations to pain and disability, and that was those that were categorized as high quality. Regarding the acromion pathology, and that was much focused on the acromion curve, there were one combined ultrasound and X-ray study of high quality that actually found an association to the between the acromion curve, the type of the acromion, and pain and function. But again, there were other studies that did not find any association of high quality, both the acromion curve and the scapular acromion angle. There was 1 low quality study that found an association between the acromion angle and symptoms. So they conclude conflicting or no associations between symptoms and the acromion angle based on the high quality and unadjusted studies. Regarding multiple pathologies, I would like to draw your attention to a poster which was presented last night regarding multiple pathologies. So please look for that poster and you will see how the association is between patient-reported outcomes and what was found during surgery, concomitant pathologies in rotator cuff, traumatic rotator cuff tears. When looking at the longitudinal studies included in that review regarding rotator cuff tears, there was an association between the tears and the tear size, increasing size, and a poor symptoms development, and also poor development of function. And that was both in tear size and in two high quality studies and two low quality studies. And again, there were two of mixed quality that did not find any association between symptoms and RC rotator cuff tear size. So they summarized based on the high quality that there may be an increasing size of rotator cuff tear is associated with an increased symptom incidence. So now I will come to our own study, and please, as I said, please no photos of this as it's not published yet. In the review by Tran, it was only very briefly described and only very few studies were drawn on the acromial-humeral distance. So I would like to draw your attention to our poster that was also presented yesterday regarding the importance of the acromial-humeral distance and self-reported outcomes or pain, shoulder pain. Of course, I had to tell you that all studies have some limitations, and our study also has limitations. We unfortunately only found a small number of studies which we could include. There was a heterogeneity in methods, and we did not make a sensitivity analysis on age. And I don't know, it's a limitation, but most of the participants were males. However, the strength of our study is that it's the first systematic review of the evidence for acromial-humeral parameters in SAPS and controls. And we actually did a meta-analysis, and we also did a sensitivity analysis of the athlete population of interest for this audience, and also, of course, the general population. We also did a quality assessment using the 27-point Downs and Black checklist. It's not either a standard, but it's a very relevant checklist to use. So we qualified and categorized each study into 3 different groups: low, when it had below 33% of the total obtained score, and moderate, and a high quality study. And I have to say that the studies included in our review were mostly of high quality. At least 75% had high quality. We had 3 aims. The first aim was to study whether there are differences in the acromial-humeral parameters between adults and subacromial pain syndrome, or SAPS, and asymptomatic adults. We also wanted to find out whether there's a correlation between the acromial-humeral parameters and pain and disability in this group with SAPS. And lastly, we wanted to study whether there are changes in pain and disability over time that are accompanied also by changes in the acromial-humeral parameters. So we included all adults above 18 years. They had to be clinically diagnosed with SAPS, and they had to have baseline parameters of the AHD, and also, if possible, the acromial-humeral ratio. And I will come back to that. we searched in the general databases as used today. And here you can see the quality assessment of the 13 studies we included. And most of them, of course, or as I said, were of high quality. Now to the conclusion, or results, I mean. We found 3 different angles of shoulder abduction that had measured the AHD in healthy controls and SAPs. And here you can see a forest plot of the included studies. First, for the general population, there was no difference on, I have to say, on the right side of the midline. This is the group with pain, showing whether it was greater, the AHD was greater, and on the left side, it's the group without pain, showing that it was greater, the AHD was greater. And there was no difference between the groups in the general population, in neutral position, neither for the athlete population in neutral position, and of course, summing up to the total group, no difference. The same goes for 45 degrees of abduction and 60 degrees of abduction. So to sum up these results, there was no difference in AHD between adults with SAPs and pain-free controls in neither 0 degrees, 45 degrees, or 60 degrees of shoulder abduction, and that was high to moderate quality. As I said, we also wanted to see whether the occupation ratio has an influence. And the occupation ratio is defined as the supraspinatus tendon thickness in relation to the total acromial humeral distance in percentage. So that tells us something about how much of the AHD space is occupied by the tendon thickness. Also, how much free space is there besides the tendon. And here we found 3 studies. And actually here you can see that there was a greater occupation ratio in the group with pain, meaning that this group with pain had a smaller space left in the total AHD. So we can conclude, only based on a small number of studies, that adults with SAPs may present with a greater occupation ratio. It was only in neutral position of shoulder abduction in high to moderate quality studies. In relation to our second aim, whether there was a correlation between the AHD and pain or disability, we only found 4 studies, and they went in many directions. As you can see, 2 of them did not show any correlation, and 2 of them showed a very small or low correlation. And I have to say that the outcome for measuring pain and disability varied between constant score and SPADI and VAS for pain. So we have to conclude that there's an unclear correlation between this distance and pain disability. To our third and last aim, whether we could see a change in patient-reported outcomes over time, which was accompanied by a change in AHD. We found 4 studies. They all improved in pain and function over time after different kinds of interventions, exercises of 4 to 6 weeks. For the first study, to the left, it was an ultrasound study of high quality. We did not see any significant change in neither neutral, 30 or 60 degrees of abduction. For the second study, also of high quality, we did not see any significant change over time in acromial humeral distance or reduced occupation ratio in neutral position. However, in 45 degrees and 60 degrees of shoulder abduction, there was an increased AHD and a reduced occupation ratio. For the third study, no significant changes in neutral position, but significant increased AHD in 45 and 60 degrees of abduction. And for the fourth study, significant positive correlations between the maximum AHD changes from 0 to 60 degrees, and that was a study of moderate
for the really
quality.
nice talk. I don't think about the muscle very often.
So to conclude on these few studies, I must say, adults with SAPS, they seem to increase the AHD minimally. Most of them were at or below the minimal important clinical effect or size at 45 to 60 degrees, along with improvements in pain and disability. And those were, as I said, of high to moderate quality. I also want to draw your attention to a poster which was also presented yesterday evening, where differences in posture correction were compared
Peter, for a
with
very nice
no
talk.
differences,
I was wondering when you looked at those
posture,
aged
a more
individuals and you
relaxed
saw a
posture,
greater
and they
area
measured
of the muscle
the
tendons,
difference in
junction.
AHD between those two
Were they sedentary
postures.
or were they active?
So to sum up, the overall conclusion
Sorry, that was animal
on the
studies. All
first
right.
review
so it
by Tran,
hasn't been looked at.
most studies showed,
really
as I said,
interesting. It's,
conflicting
great
results.
thing.
There were few studies on each of the areas. Many in the Tran study were of low to moderate quality and they were unadjusted. However, in our study, most of the studies were of high to moderate quality. To sum up on the different conditions in the shoulder, there were conflicting or no associations on symptoms on rotator cuff tendinopathy, acromial pathology, this AHD distance, and also as you go to the poster and see on the multiple pathologies. However, there were positive associations to findings on symptoms and pain in the more longitudinal studies, on the rotator cuff tear size, on the SAPS, on the occupation ratio, in those studies I showed. So the implication and the conclusion overall could be that we need to understand the relevance of these image-detected pathologies in order to find the roles in management and to improve care and reducing costs. And to conclude on our own study, the implications of our study could be that management of SAPS should not only focus on addressing the acromial-humeral distance, but also prioritize the importance of the supraspinatus and the thickness especially. So thank you very much for your attention.
Well, thank you, Birgit. I think we have time for a few questions before Karen will take the floor.
Well, thank you for a nice study. So if I understand correctly, what you've actually discovered is that it's more the morphology of the supraspinatus tendon than it's actually how the bone looks that matters.
Thank you for your question. It seems so, but as I said, there were some limitations. It was only a few studies, but that was how it seems. That the only distance, the acromial humeral distance, does not seem to make the difference between those with pain and those without pain. It's more that's inside. It's the free space next to the tendon thickness that may be of relevance.
But did you look at the thickness of the tendon? Because, I mean, the reduced occupational space is probably related to increased thickness of the tendon. Did you look at the actual thickness of the tendon? Because I would think that was more interesting.
I totally agree with you, and we looked at the tendon thickness in the way that we looked for the occupation ratio, and that means that the kind of size of the tendon that occupies the acromial-humeral distance. And in that outcome, we saw a difference between those with pain and those without pain. So you are really right.
Okay, no more questions? Well, then I'll ask you one. Do you think it's the methodological quality of the MRI and ultrasound studies that make this inconclusive findings, or is it just because we don't need to use MRI and ultrasound in diagnosing these patients?
I'm happy to hear this question, and I will hope that we will have time to also discuss it afterwards in more general, because when looking at the studies that were included in both the TRAN review and our review, there was a large heterogeneity in how the measurements were performed both by ultrasound and by MRI, and the population was also very heterogeneous. So that I think that we have some way, maybe not a too long way, but we have some way to go to be more, to get more knowledge within this area.
Okay, thank you. And our next speaker is
Yes.
Karen McCreesh from the University of Limerick.
Yes, I'm on. No, the other one, sorry. Back there. This one, yes. You ready for me to go? Yeah? Okay, good morning, and huge thanks to Birgit for inviting me to join the session here. I'll hopefully follow up a little bit on your tendon thickness question, so that moves nicely towards what I'm going to talk about. So I'm going to talk about some primary research rather than systematic review, looking at the short-term effect of fatigue loading on the thickness of the supraspinatus tendon in the context of this idea of the subacromial space. And hopefully then conclude with some discussions around how this maybe could have some implications for managing your patients with exercise therapy. They don't let me out of Ireland unless I do some public relations, so I better do that bit now. I'm from here, which is a little city on the southwest of Ireland called Limerick, beautiful riverside city. This is my university, University of Limerick. We straddle the Shannon River. It's by all accounts, the most beautiful university campus in Ireland, so please do call and visit us if you're nearby. Our claim to fame is that we are the All-Ireland champions for this insane game called hurling. To make a Scandinavian equivalent, it would be a bit like the ferocity of handball, but on grass with sticks, okay? So we're really good at this, so watch out when you come to visit us, okay? So we're going to talk about shoulder pain today, and Birgit's already done some of this already. So the EU prevalence. So shoulder pain is common, it's highly prevalent, 15 to 20% prevalence in Europe. It's persistent, so about 40% of patients are still experiencing shoulder pain after 12 months from when they first seek care. And it's disabling. People with shoulder pain have poor quality of life and high rates of psychosocial comorbidities. I'm going to look in detail at some of the mechanisms around rotator cuff tendinopathy. This is a paper from Amy Seitz, an American physiotherapist from 2011. She divided the mechanisms of rotator cuff tendinopathy into those that were intrinsic, so things that were directly influencing tendon physiology and healing, things like load, age, genetics, lifestyle factors, and the vascularity of the tendon. And then she separated out what we call the extrinsic mechanisms, which were more the mechanical factors that were external to the tendon, things that perhaps some of us are more or less fans of, the subacromial space, scapular kinematics, and the muscle dysfunction. That's not to say, I'm going to focus mainly today on this aspect, the load and how that might influence the subacromial space. We're not pretending this doesn't exist, okay? So I'm very much saying, elephant in the room here, is that we know that psychosocial factors have enormous influence on pain and recovery in all musculoskeletal conditions. What I am saying to you is, we're focusing on the structural element today, but this is a big overlay for any of our patients in terms of recovery. Okay, subacromial space, where is it? It's here, underneath the acromion. It measures around 1 centimetre, as you can see from the review that Birgit did. Loss of space is certainly observed in significant cuff tears, but again, from the work that Birgit's just done, we see that in people with less significant cuff tear pathology, so people with tendinopathy or subacromial pain syndrome, we don't see big changes in acromihumeral distance. Why might it be different? Well, we believe as physios, I suppose, particularly that superior migration of the humeral head due to cuff insufficiency might reduce the space. Bony thickening or encroachment from osteophytes might reduce the space, and so might also alter kinematics or scapular position. And again, I'm going to acknowledge that I'm not going to talk a lot about scapular position in my work. I focused much more on the ultrasound measures of the subacromial space. So what's out there in terms of understanding tendon thickness changes in tendinopathy? So there are 2 systematic reviews that have looked at this idea, understanding the acute tendon thickness changes with exercise in pain-free tendons. That was done by Tardioli back in 2012. They managed to look at these 5 studies. One of these assessed the shoulder, and they only looked at the biceps tendon in wheelchair athletes. So quite a specific population and just the biceps tendon. The other, all of the other 4 studies they looked at thickness of the Achilles tendon under load. Okay, so all of these studies looked at acute changes in tendon thickness, and 4 of them were Achilles and 1 in the biceps. And the conclusion was that tendon thickness reduces with acute loading, so this is with a single bout of heavy exercise, in healthy tendons. So when we expose a healthy tendon to exercise, various types of exercise, it should reduce in thickness to some degree. We've got another systematic review here again, which was focused only on the Achilles tendon, looking at morphological properties and the effect of loading. And then specifically here, looking at, sorry, now I'm going to focus in on where we are, the diameter, which included some studies that looked at cross-sectional area and some that measured thickness. Okay, so we've got a forest plot here that suggests that post-exercise in the normal Achilles tendon, and these are all studies looking at normal Achilles tendons, the thickness of the Achilles tendon reduces. So again, reinforcing the results of the previous review. Down here, we have someone who looked at tendon volume because they had an MRI study, and they looked at a symptomatic population. And in the symptomatic population, they reported that, in fact, tendon thickness increased post-exercise. So this was the only one that was there was one symptomatic group here, actually, which had the opposite result, actually suggested that there was a decrease post-exercise. But here, we've got one using MRI suggesting that in people with pain, there's a different response of tendon thickness to load. Okay, so nothing on the rotator cuff has been done before in terms of looking at the response of the tendons to load in terms of tendon diameter or tendon thickness. So therefore, that's why I decided to undertake this piece of work, examining the response of the Achilles tendons to load. I suppose I was also quite interested in this idea of occupation ratio. You know, we can see a thick Achilles tendon, we can't see a thickened supraspinatus tendon on the outside. And so I guess I'm thinking, well, what happens if we put that into this relatively limited subacromial space or bony space? Is there an interaction effect here to any degree? We know the tendons get thicker with loading if there's tendinopathy. But what is the impact of that altered tendon thickness now in a space where there's relatively little room for maneuver? So this was really the subject of my investigation. Just getting through the methodology briefly to convince you that we did some high quality work. So we started off by looking at what was the most reliable and valid method. This is published in BJSM. Systematic review of 18 studies that suggested ultrasound's the most reliable method to measure subacromial space, but there were problems with no data in symptomatic populations for reliability, and there was no data on validity, which is very bad news when you're going to do a study, because then you've got to go and do the validity study. We did that. We did it very much at the bench, using an ultrasound phantom 3D printed shoulder bones. If you're interested in that sort of stuff, please do feel free to read. But the outcomes were that it did provide support for the construct validity of measuring the subacromial space using a 2D method, which of course could be challenged. It's very much a 3D space. But can we, using a 2D slice method with the ultrasound, get a valid measurement? And this study suggested that we could. And then I also conducted a reliability study, both inter and intra-related reliability in symptomatic populations, which suggested there's excellent reliability for measuring the subacromial space and the thickness of the supraspinatus tendon. And it also, we generated in that study the minimal detectable change values, which were important for interpreting the subsequent study. Okay, so this is how we measure it if anyone does ultrasound. So here's the acromion, this is the humeral head, and we measure then the parallel distance from the tip of the acromion down to the humeral head. You can see that the supraspinatus tendon is this structure here, and if this was moving, you'd see that this would be back and forward underneath the acromion. Here's where we're actually placing the probe. And for measuring supraspinatus tendon thickness, again, here's where we're placing the probe. This is what we view, so it's a transverse view of the supraspinatus tendon. We use the long-headed biceps as our landmark for measurement, and we measure in 2 different areas, a set distance from the biceps tendon, and take an average of these 2 measurements. Okay, so again, that method is described in our reliability study if anyone wishes to replicate it. So here's the main study. We were looking to examine the 24-hour response of the subacromial space and the supraspinatus tendon to a single bout of fatiguing exercise. And as a clinician, the way I see this is that people are normally imaged when they've sat in, at least in Ireland, when they've sat around a radiology department maybe for an hour waiting for their appointment, and then they get their imaging. I was much more interested in saying, well, what happens when we image people when they're provoked, when they're painful, when they've done the thing that makes them hurt? So this was sort of imaging people after a provocative activity. What do? We took 20 controls with age-matched, pain-free controls, and 23 people with rotator cuff tendinopathy. That was ultrasound diagnosed as well as clinically. We developed an isokinetic protocol to create rotator cuff fatigue, and this was based on a protocol that had been published by Jean-Sébastien Roy in Canada, which he used in occupational health settings. We used both abduction and external rotation, both concentric and eccentric muscle activity, and the aim was to get 35% fatigue of both abduction and external rotation directions. So all the patients had to get to that level of fatigue during the protocol. We scanned them before the exercise, 1 hour after the exercise, 6 hours after the exercise, and again the next morning, so pretty tired of us by the end, 24 hours after they completed the exercise. Our participants with pain completed slightly fewer exercise sets to get fatigue, but actually not a statistically significant different number of exercise sets. So in fact, both groups responded very well to the protocol and were well able to complete this protocol and achieve the 35% fatigue that we were after. Here are a description of the population, so an even number of males and females. They had had symptoms for around 13 months with a range of 8. Their pain level was around 4 out of 10, disability 25 on the SPADI. So these were not highly disabled, these were not extremely painful patients, and that was deliberate because we knew that we were testing this protocol. We didn't want people with very severe symptoms because they may not be able to complete the protocol. However, this group were comfortably able to complete the protocol, so I suggest that we certainly could have done this in people with slightly higher intensity of symptoms. On ultrasound, 17 of them had supraspinatus tendinopathy and 6 of them had a partial tear of their supraspinatus tendon. They were excluded if they had a full thickness supraspinatus tear. Okay, so here is the data for the subacromial space before, 1, 6, and 24 hours after the fatiguing rotator cuff exercise. On the left, and we expected this, was that both groups got a significantly reduced subacromial space 1 hour after fatiguing exercise. Other people have found this in studies of occupational health populations. We expect that when we fatigue your cuff, the subacromial space reduces because your humeral head has migrated upwards. So this, as expected, our controls got a slight reduction in their subacromial space at 1 hour, but by 6 hours it was completely returned to baseline and was also at baseline at 24 hours. In our group with pain, they got a bigger reduction. So again, at 1 hour, they got a large reduction in their subacromial space. This reduction was also lower than baseline at 6 hours in our rotator cuff tendinopathy group. Okay, so they had a sustained reduction in the subacromial space, but all had returned to their normal subacromial space by 24 hours later. Okay, now I'll present the data for the supraspinatus tendon thickness, obviously measured concurrently. So the controls had no significant changes in their supraspinatus tendon thickness at any time point. So remembering back to the Achilles data, which suggested that in a normal tendon exposed to this type of exercise, you should get a slight reduction in tendon thickness. We did see a slight reduction, but it wasn't statistically significant. So very small reduction, and it wasn't greater than our minimal detectable change value. So therefore, I can't report it as a reduction. So what I'd be saying is, in our group, their tendon thickness essentially did not change. In our rotator cuff tendinopathy group, there was a statistically and clinically, or sort of above the minimal detectable change value, increase in tendon thickness of around 11% at the 1 hour time point. And this was sustained and actually increased further at the 6 hour time point. So they continued to get tendon swelling right through to the 6 hour time point. On average, they had all returned to baseline by the 24 hours, but obviously we didn't measure them between 6 and 24, so I can't tell you at what point did they come back to normal. But the key difference here was that they got a thickening of the tendon, which was sustained. So in discussion around this, well, we said fluid extrusion post-exercise should mean that the tendon gets thinner after you expose it to this type of exercise. That's what happens in the Achilles. We saw the opposite response. So we saw swelling in our rotator cuff tendinopathy group, which suggests that there's an abnormal fluid metabolism in these tendinopathic tendons, and suggests that what we're seeing here is a primary tendon pathology as opposed to a tendon pathology that's driven by compression from the subacromial space. Okay. There was a delayed recovery of subacromial space after rotator cuff fatigue, particularly in the tendinopathy group, and as we would identify easily as physiotherapists, this would implicate muscle dysfunction, so that they were less able to recover from fatigue, suggests an endurance impairment in these people's rotator cuff muscles. So the question then comes, does this enlarged tendon, when you combine it with a superiorly migrating humeral head, increase now the potential for the tendon to be compressed, but more as a secondary phenomenon, not as the primary thing that's driving this pathology? I just want to apply this to exercise prescription. So it is a small study. It needs to be replicated. It was done in a lab environment, so obviously we need to carry it across to clinical environments as well. What we might suggest is exercise to fatigue in people with high irritability probably isn't a good idea. They will take long periods to recover their subacromial space and their tendon homeostasis. But again, we instinctively know this in most of our clinical classifications, that we don't work these highly irritable people to fatigue. We may consider loading only once a day or even every second day, as opposed to twice a day loading, for example, in order to avoid fatigue. We might consider limiting our exercises to 1 or 2 only for cuff loading at any one day to avoid excessive rotator cuff fatigue. But I think the key issue for us in athletic populations would be this real need for a load management plan for chronically loaded people. And this would be your athletes in your peak seasons, your swimmers heading off on the swim camp, and your manual workers in their peak season or their time of most work. Managing load to avoid persistent or chronic fatigue of the rotator cuff might be fairly important in terms of improving tendon homeostasis for the rotator cuff tendons. And then just briefly some future directions. So this is one application of our protocol that's already been made in the sort of athletic setting. So this is a group from Australia, published by Porter et al. It's only been published as an abstract to date, so the full paper is not yet available. So they took our protocol, they measured supraspinatus tendon thickness, AHD and occupation ratio at baseline 1 and 6 hours after swim training. And they noticed that there was an increase in supraspinatus tendon thickness in just the swimmers who had painful shoulders. And like our study, this increase in tendon thickness in the painful group was sustained beyond 6 hours. So, what I'm thinking, and they agree with me, is that, this potentially has an idea that it could be a method of examining tendon resilience to load in these type of athletes, is looking at this longitudinal response of the tendon to load. It's much more dynamic than a single or once-off imaging investigation.
For some nice
There's certainly much more potential for using ultrasound in a more dynamic way to look at the way that athletes are responding to load
really
in the
essential
shoulder.
in our treatment of
the next part that is interesting for us to think about is thinking about this more longitudinally. So this is thinking about do any of these subacromial parameters relate to outcome with rehabilitation? And lucky for me, I can stop now because Kim is going to take over on that point in a moment or two.
fibers were running
I'm grateful to my collaborators and also to the Health
chronic
Research
changes that
Board
you saw.
who have funded some of
So
this
do
work.
you think the
Thank you.
chronic changes are at the myotendinous junction, or the image that you presented is actually the myotendinous junction, or that's further out away from the images?
Thank you very much, Karen, for this nice presentation and overview also. Are there any questions from the audience? Otherwise, I will have one question. Yes.
Thank you, Karen, for your very clear and interesting presentation. I just have a clinically practical question. Would you then, with this, recommend clinicians to actually use more often medical imaging during their treatment or therapy, or is at some point any valuable addition from medical imaging in the exercise prescription?
And we're going to take that up at the end, I think, in a bit more detail, Celine. So I don't see it in your average population in clinical settings. There probably isn't a huge bonus to this. We will probably gain more from patient self-report measures. However, in athletic populations where athletes are getting a lot of acute loading, and that we know from the training load data that can have a big influence on injury rates, then I think this could be a nice addition to thinking about training load, because it's often looked at as volume and RPE. We saw that in the presentations yesterday. But could we actually add this, because we can see the physiological response locally in the shoulder
Is it
for
possible
athletes who
for
are
me to
loading
follow
their
up
shoulders
and
acutely,
just have you show the images?
and who may be
'Cause
vulnerable,
I'm
particularly
not sure I
I think
understand.
swimmers are the big example for me, to actually training load
So
related
we had
injury. So there could be populations
Peter
that work.
Magnussen
I think your
initially
average rotator
talking
cuff
about the surface
tendinopathy
area
patient,
that we have.
no.
Yeah,
But I think
this one
bespoke
here.
groups where
So
they are
and
doing
can
acute
you do the
loading,
one
this could be a
before
useful
that?
way to track what's going on.
So we have the surface area, and we see that, on the right side we have the healthy human
Question?
tendon, and the fibers follow in
As I
to the
recall in your
collagen
study,
fibers, and you get
you
this
also measured pain.
interdigitation.
And
On
I
the other
also,
side,
as I
we
recall,
have the muscle fibers parallel
see
to the
any changes in
disorganized
pain.
collagen that you have,
So
and we don't
is-
see
has it any
where
relevance
I would assume
the
that they
tendon
would
thickness
enter
is
into
increasing?
the collagen.
So we measured
of the
pain
tendon.
at each
So
time
do you
point.
think this
And it was a
disorganized
small group, so 23 people.
area that you
so
have?
even running the pain data was a bit
Because it's
dodgy.
said line-
and
yeah.
I like to do my statistics well. So it wasn't something that we wanted to look at too much. It wasn't a big enough study to do that. I could say to you anecdotally that there were only 4 people who did not have tendon thickness that returned to normal the next morning, and those 4 people had the highest numerical rating pain scale scores. But 4 people, it's a cohort of 20-30, so that definitely needs to be done.
So
on a
have you
bigger scale.
seen in your
But
sample
of the 4
a
people who
change
did
in
not
the
have
surface area or
back to baseline tendon
the
thickness the next morning,
interdigitation
they were the
post-injury?
4 with the highest levels of pain.
Suggesting
But as I said,
a
too small
lower
to analyse and not
surface
something that I
area
would pursue to any great degree.
of the
so
yeah, on,
there is
on the 6
maybe a
months,
small
or just compared to
indication
health
There
that
could
this
be a trend, yeah.
tendon swelling
these-
may be a
these biopsies.
preclinical sign.
There could be, and again, the swim study suggested that they saw a trend towards that. So we
No,
just need
just
a bigger
compare,
study in.
like
So in my
for
group,
healthy
probably
to-
were
yeah.
they were an average sort of community population. I think looking at this in a swim, and we're doing it with Swim Ireland at the moment with some elite athletes to look at actually in the swimmers where they're doing this acute loading, are we seeing this as a measure that might be useful, predictor of pain, predictor of recovery, predictor of something useful? Yeah.
We still have to have some questions.
Thank you very much for your presentation. Actually got 2 questions.
You're welcome.
So, the first thing I really didn't get, you did that 35% fatigue. Could you please elaborate on that?
So the protocol has been published already before by Jean-Sébastien Roy, and they use it in occupational health populations and people who are doing a lot of overhead loading. So we essentially took their protocol and applied it directly because they had very successfully achieved the 35% fatigue. The Biodex dynamometer measures the fatigue for us. So on the dynamometer, we set them to do the repetitive concentric and eccentric loading, and we look at the I think it was total work we used. I'm going to have to go back and look exactly, but I think it was total work. So once the total work over a set of 5 repetitions had reduced by 35% from their first attempt, that was what we determined as 35% fatigue. So it was during the Biodex protocol, they got 35% fatigue in abduction, and we also then gave them 35% fatigue in external rotation using the bidex dynamometer to measure.
But you didn't, the fatigue means that, you do exactly, I don't know, about 30 repetitions, and then you can't do it anymore, right?
No, so it wasn't that they couldn't do it anymore. They just had to have a 35% drop in the amount of force that they could use compared to the first set of repetitions.
So it
wasn't to failure?
Okay,
absolutely not.
All right, okay, so it's drop in, okay.
So it was a drop from their first set of repetitions. Once the set of repetitions dropped to 35% below their first set, we determined that was enough fatigue.
So, all right.
So this was not failure.
No. Okay, I'm very interested in about the minimal detectable change. So you said, correct me if I'm wrong, that you had about 11% increase in the supraspinatus thickness?
Yeah.
Yep. That's the mean value, kind of. But for how many of those patients actually there was more than the minimal detectable change?
And again, and I did just report data on 4 patients, but I hate doing that because I don't think it's a very valid way to report these sort of studies. I don't know how. So that 11%.
So what I'm saying is, if
the
you
mean change was greater than MDC. So that 11% is greater than minimal detectable change. Exactly how many of the patients were either side of that cutoff, I can't tell you, but I suspect half and half if we're getting a mean of around that level. So that overall mean change exceeded the MDC. Exactly how many patients were on each side of it, I can't tell you for sure.
It's just if you want to use it clinically, that's the thing.
Yeah, so it's there. So that's based on our reliability study, that minimal detectable change. So that's valid. And I think anyone who's taking on ultrasound as a measurement needs to test their own reliability because there's very huge observer-dependent elements of ultrasound. So I think you need to test your own reliability. I tested mine, and obviously I was the one doing the scanning.
So if I understand you right, so 50% of the patients, half of the patients, they would not have a higher than the minimal detectable change.
I suspect not. I can go back into the data and tell you for sure, but I suspect statistically that's probably what we saw.
Okay, thank you very much.
You're welcome.
Okay, I think we should close the discussion now and take the more general discussion after Kim Ingwersen's presentation. So thank you very much.
Well, thank you, Birgit, and thank you for the organizing committees for inviting me to do this talk about the longitudinal effects of exercise on supraspinatus tendon thickness in patients with rotator cuff tendinopathy. And this is some secondary analysis of the ROCTIX trial. And I'm a physio at the Department of Physio and Occupational Therapy at the Lillebælt Hospital in Vejle here in Denmark. And this is actually my first day as a postdoc at the Department of Regional Health Research, University of Southern Denmark. Before going into the details about the longitudinal aspects, I'll just briefly touch upon this table 1 from the Giris trial in 2011, which were looking at asymptomatic findings, shoulder findings on ultrasound in 51 men. What they find is that 78% of the healthy participants had a subacromial subdeltoid bursal thickening. They also find that 65% have acromioclavicular osteoarthritis, and 39% has signs of tendinosis. So just looking at this and saying this is asymptomatic participants, then what can we use ultrasound for when we see patients in the clinic? At least you should do yourself the favor of scanning both sides of the shoulder to see if what you find on the symptomatic side just is a normal finding, or if it's relating to the pathology that the patient have. Where I find ultrasound to be way more interesting is in the case of using it for selecting patients into different subcategories, and maybe using it to guide our treatment strategy, or maybe predict the effect of a treatment. And if we look at this, then in relation to tendons and tendinopathy, structural changes and ultrasound and patient-reported outcomes, Drew et al. In 2014 made this systematic review, looking to compare patient-reported responses, being function, pain, treatment, satisfaction, with ultrasound verified structural changes. In this case, that's neovascularization, structural abnormalities, and tendon volume, cross-sectional area, and tendon diameter. In trials that use some type of active exercise interventions, mainly eccentric or heavy slow resistance training or medical exercise therapy. What they found based on 20 articles, or what they concluded, is that the available evidence does not support that observable structural changes is an explanation for the response of exercise, except for some support from the heavy slow resistance training. And I also remember that Bill yesterday talked about that heavy slow resistance training might be the way to go in the future. But in this systematic review, you just have to point out that the 14 of the studies, the trials, is being performed on the Achilles tendons, and only 2 of the trials were evaluating the heavy slow resistance training. And also the majority of the trials had high risk of bias, and this includes also the 2 trials focusing on the rotator cuff tendinopathies. So overall, I would say that in general, and especially for the rotator cuff tendinopathy, we lack evidence. So we need some future high-quality longitudinal trials and high-quality randomized controlled trials that measures these structural changes on ultrasound to see what impact changes have in relation to patient-reported outcomes. Luckily, in the ROCTEX trial, we used ultrasound both at baseline and also at 12 weeks follow-up. So we might have some results or data that can shed some light on these aspects in the longitudinal perspective. So the ROCTEX trial has previously been published as a study protocol in trials. It's basically just a traditional randomized double-blinded controlled trial. We included 100 participants from 3 hospitals in Denmark. And we only included patients that had a unilateral diagnosis of rotator cuff tendinopathy. And the patients were randomized to either 12 weeks of traditional low-load exercises or progressive high-load exercises. The primary results we published in the Orthopedic Journal of Sports Medicine, and the primary outcome was the patient-reported outcome measure being DASH. And what we found was that there was no difference between high-load and progressive high-load and low-load exercises on the patient-reported function. But that's not what I'm going to go into detail with today, because that's the change in tendon thickness from baseline to 12 weeks of follow-up, and this change in relation to the patient-reported function. So the purpose is on ultrasound captured images to evaluate. There's a lot of aims, I know, sorry. If 12 weeks of rotator cuff exercise influences the supraspinatus tendon thickness, if the stage of tendinopathy, and this stage of tendinopathy, I will come back to that later, if that influences the changes seen in tendon thickness, and also if type of exercise modality influences the tendon thickness, and maybe the most important part, at least for the patients, if the stage of tendinopathy influences the self-reported shoulder function, and also if exercise modality has an influence in this. So for the ROCTEX trial, we included patients based on that they had to have a low pain at rest, increased pain with movement, and a largely restored range of motion. And patients were between 18 and 65 of age. They had to have some clinical tests positive, and this was either NIAS or Hawkins-Kennedy test, and also one of full-can, empty-can, or resisted external rotation test. And then, of course, they needed to have some signs of tendinopathy verified by ultrasound examination. So that could be fibrillar disruption or hypoechoic areas, calcifications, neovascularity, or differences in tendon thickness in relation to the contralateral healthy side. The intervention were 12 weeks of progressive high-load exercises or low-load exercises, and both groups received the same basic information. They received the same 6 exercises. They were given the same attention, so we saw them the same amount of times at the hospital. And the exercise program is planned, so the time on the load and the total load in both the high load and the low load exercise group is the same. So the difference between the two exercise modalities were on the scaption and the external rotation exercises, that the mean load per repetition was different. And we attained this by making the progressive high load exercise group going from 60% of one repetition max up to, in week 1, up to 85% in week 9 to 5, 9 to 12. Whereas the low load exercise group from week 1 to 12 performed approximately 50% one repetition max throughout the exercise trial. In these secondary analysis, we of course needed to have baseline ultrasound measurements and also a 12-week measurement. So that's inclusion criteria for this part of the analysis. Also, we wanted to adjust for exercise compliance. So we only include people that had their exercise diaries returned at 12 weeks of follow-up. So we end up with having 68 participants that we could make these analyses on. The method we used for obtaining the images for the tendon thickness has previously been reported in the BMJ Open article, but the participants are seated with the shoulder internally rotated, with the dorsal side of the hand placed on the sacrum. So that's a small difference from the way you are performing it, with the hand placed at the side of the hip. And then an image is captured at a fixed point just laterally to the anterior lateral corner of the acromion in the longitudinal plane of the supraspinatus. And the tendon thickness was defined as the height from the humeral head at a point approximately 20 millimeters from the supraspinatus tendon insertion, and then up to the most superficial part of the tendon. And the inter-rater reliability of this method is excellent, and also the minimal detectable change at group level is reported to be 0.33 millimeters. So that's quite low. So coming back to this stage of tendinopathy, when we look at trials looking at the patella and Achilles tendons, we always hear them say that they included tendons that were swollen or thickened as an inclusion criteria. But for shoulder patients, we often see that patients have a degenerative tendon. So the tendon is thinner than the opposite side. So based on the continuum model of tendinopathy by Cook and Purdom in 2008, we subgrouped the patients in what we call normal. And in this case, normal is not a healthy tendon. It's just normal in comparison with the thickness of the contralateral tendon. Whereas the reactive tendons were more than 0.4 millimeters thicker than the opposite side, and the degenerative tendons we defined as being more than 0.4 millimeters thinner than the opposite side. So that's an important change from how we normally look at structural change over time in other studies, because they're not used to doing the subgrouping of the patients. So before going on to the results, I'll just like to point out that this is unpublished results, so please don't take any photos of the results, because it might make it difficult for us to publish it. and I really want to give all of the data out to everybody and not only the people sitting here today. But the first aim were if 12 weeks of exercise, of rotator cuff exercise, influences supraspinatus tendon thickness. And if we just take the entire group, not looking at the progressive and low load exercise groups modality, we see that there's almost no change in thickness from baseline to follow-up. And the same is seen when we look at the two exercise groups. They go in opposite directions, but the change is quite small, only being approximately 0.05 millimeters. And it's nowhere statistically significant. So if I just put this slide on and say that's the conclusion, I would say 12 weeks of exercise don't change tendon thickness in rotator cuff tendinopathy. But if we then look at if states of tendinopathy influences the changes in tendon thickness, then we find this. And basically what you see is that in, I don't know what happens here. It should be reactive. In the reactive group, which is the patients that had a thickened tendon at baseline, we see a decrease in the thickness of the tendon after 12 weeks of exercise. And for the degenerative group, who had a thin tendon at baseline, we see an increase in tendon thickness. Thanks. So for the reactive group, it's not statistically significant, but it is a small subgroup. So if we had some more patients, we might have seen a statistically significant change. But the change is the same as the minimal detectable change for the method of the ultrasound. In the degenerative group, we see that it's statistically significant of 0.49 millimeters. Whereas in the normal group, so those patients that already had a tendon size that were equal to the opposite side, they don't change at all after 12 weeks of exercise. So this basically means that the tendon tends to normalize after 12 weeks of exercise. So where Karen finds that they have an increase in tendon thickness, over time it might flatten out and results in a normalization of the tendon thickness. So the next question is if the exercise modality influences these changes. And overall, you can see that the direction is the same for both the progressive and the low-load exercise group. And there's no significant difference in these two examples. So exercise modality don't influence these changes. So the next question is if states of tendinopathy influences the changes in self-reported function. And if we just take a look at the three tendon stages, we see that there are no significant difference between them. The highest effect is seen in the reactive group, and you could argue that the degenerative tendons are not reaching at the minimally clinically relevant difference or change. But in relation to that, I have to say that the baseline DAS score for this population was quite low. I think it's about 22 DAS points at baseline. So in relation to that, the change is actually okay. It's about 30-40%. If we then take a look at the impact of exercise modality, we find this. And this is partly some of the explanation why the change for the degenerative group before on this slide were lower than the two other groups or stages. Because people with a degenerative tendon performing progressive high load exercises have almost no change at all. And maybe you're sitting and wondering, thinking that, yeah, of course, a degenerative tendon putting progressive high load exercise on that kind of tendon, that's basically a stupid idea. But well, we didn't know at the time that we started this trial what impact it would have. So now we've just been able to confirm that using high load exercises in a thin tendon might not be the optimal way of treating them. The between group difference is 10.3 dash points, which is approximately the same as the clinically relevant difference, and it's almost significant. So had we just had 1 or 2 more patients in this group, we probably would have seen a significant difference between this also. And if you look at this change in the progressive high load group and also in the reactive group, you could argue that it's not clinically relevant improvements. So for a reactive tendon, we should use the progressive high load exercise intervention. So the principal findings is that overall exercise did not change tendon thickness. However, when we analyzed it according to tendon stage, reactive tendons decreases in thickness and degenerative tendons increases thickness, and the same effects are seen of both exercise modalities. And the tendon stage might influence the effect of the exercise modality on patient-reported function and pain. However, there are some pitfalls in this because it is based on small sample sizes and subgroups, and it is secondary analysis of data from a randomized controlled trial. So doing these sub-analysis, it's no longer a randomized trial because it is a selected population. So be careful when you are interpreting these results. And also another part is the reliability of the ultrasound measurement method for repeated measurements over time is unknown. So there might be something to think about there also in the future. So a hopeful but cautious conclusion would be that active exercises tend to normalize tendon thickness in comparison to the contralateral tendon. Progressive high load exercises may not be the most ideal way of handling patients with a degenerative tendon. Low load and progressive high load exercises can both be used in patients with normal tendons, and in normal, again, it's only in relation to tendon thickness. Progressive high load exercises may be most effective in patients with a reactive tendon. And bringing this all together, we might be able to use ultrasound to evaluation of tendon corrective to assist in guiding the treatment strategy. But of course, we need further trials to be performed to confirm the secondary results from the Rotator trial. So if anyone is sitting and saying, okay, we have a lot of these rotator cuff tendinopathy patients and are using ultrasound in daily clinic, then please come and talk to me, then I will gladly be a part of a future study on this. And finally, I would just like to acknowledge all of my collaborators and funders for the Rotator trial, and thank you for listening.
Thank you very much, Kim. And this is now open for discussion. Katrine?
Thank you. I must congratulate you with a very good study. Did you include a wait-and-see group? Because do you know the natural history and for the thickness of a tendinitis tendon during, it was 3 months, I guess?
Yeah. Sadly, no, we lack the knowledge of that part. And of course, it would have been beautiful to have a wait-and-see group just to see what would happen in that case. But no, sorry.
Thank you very much. Very interesting indeed. What I was actually thinking about, you said about the sub-analysis, that we should be very cautious. have you been doing a kind of a power analysis on it?
No, not yet.
Because actually it could be quite strong results if you did a power analysis on it. So it could be probably about 80% or 90%, you don't know.
No. We haven't done that yet, so we could consider doing it before publishing.
So when you did the reliability study, did you look at, well, you used the ultrasound to look at the difference between the two shoulders, right?
In these data?
Yeah, normally when you in this study, use the difference between the two shoulders, right?
Yeah.
Yeah. So did you do the reliability on the difference between the two shoulders as well?
We have compared in a healthy population what the difference is between the thickness in and it's a minimal change or difference there's between the two sides in a healthy population.
Yes, but that's not the reliability study that you did. Did you do it between the different two shoulders? So you measure that shoulder, you measure that shoulder, you look at the difference, and then you did it again?
No, we have not looked at the difference between the two shoulders and the reliability of doing that. We have measured, well, we could do it because we have measured when we performed the reliability study. Yeah. We did it on both sides.
All right.
So we have the data for it.
Okay, that could be very interesting.
Yeah.
Okay.
But I guess I don't know if it would change the reliability.
I don't know either.
But yeah.
Thank you very much.
Yeah, thanks.
Do you think the large number of dropouts have any influence on the data?
Well, I don't think it'll have a direct impact on the results, but what we see is that we have a larger dropout in the progressive high-load exercise group. So, but some of them were mainly people we were just unable to contact at 12 weeks of follow-up. And also a proportion of them had just not delivered the exercise diary. So they came in and we have numbers for their dash and everything else, but we didn't have their compliance to the exercises. But definitely dropouts is always a major concern, and that's also why I say we should interpret these data with cautious, and we should do another trial just looking at these measurements in relation to the patient-reported outcomes, because we can't trust these data 100%. So, but I'm hopeful, and I think it's quite a clear direction it moves the data.
Thanks for a great talk, Jess.
You
showed that
be looking at. And especially this part of dividing the patients into degenerative and reactive tendons instead of just collapsing
how cells are affected.
The patients.
Do you suppose that would be different if you had dynamic loading of the system?
Hello. Yeah, it works. Thank you for a nice presentation, Kim, and congratulations on a nice study. I was wondering, since it seems to me that the low-load training works equally good in all groups and could be the reasonable choice for every patient, or maybe I misunderstood something, but if I'm right, does it make sense to actually do the ultrasound measurements then if we could just apply low-load training to all of the patients and get good results?
Well, yeah, you could say that, and thank you for the question. What we find is that, especially for degenerative tendons, you shouldn't use high-load exercises. In the reactive tendons, there's a trend going towards that the progressive high-load exercise is more beneficial. It's not statistically
Thank you very much for a
significant
great talk. So you showed that HIF-1 alpha when you blocked it, you had an effect. But did you also show that, maybe I missed it, but did you also show that HIF-1 alpha was upregulated in your high oxygen temperature condition?
It was effect on patients' function and outcome, function and pain. So before doing the large-scale study, we can't say it's if we just can use low-load exercises on all patients. If that's answering your questions. Yeah.
Okay.
So maybe we can a more general discussion now. Karen and Kim, how do you see ultrasound measurements in the future for surgeons and physiotherapists?
Thank you for
Is
a
it
great session.
feasible?
I have a question for
Can we
Monica,
use
if
it? Can
that's-
everyone
if
use
that's
it?
okay?
And when can we use it? When can we not use it? Can you both
Sorry.
elaborate a little bit about that?
Congratulations with great
Well, if
studies.
I have to say
I just
something
have a
to
question,
start with, I
based
guess
on your findings,
we should be
how
careful
much do you
using
think we should
ultrasound,
emphasize
at least when
time
we are using it
versus
to
more,
make a diagnosis.
criteria-based or functional-based
But I think it's
rehabilitation
okay
programs
tool to confirm the clinical
for muscle
diagnosis
strain
we've made.
injuries. So time
But
versus
hopefully
criteria-based
people will start thinking about using it more to
rehabilitation
subgroup
programs.
patients, at least in relation to tendinopathy, which is the area that I have any knowledge about. But I think the method is important, that you use a standardized method, and as Karen also saying, that you are making reliability measurements on yourself, because it is a huge problem that it is so observer dependent.
So I am trained as a sonographer as well as a physiotherapist, so I suppose I come from the perspective of that training is extremely important, and the most important part of that training is the mentorship. So mentorship from an appropriately qualified radiologist or sonographer will always be my primary thing that I will say to physiotherapists who are interested in developing these skills, and that there's a huge observer-dependent element of it, and that what you miss is much more important than what you see. So caution is feeling like the word of the day, but I suppose as someone who's trained as a sonographer, I would have to take that line. That's not to say that physiotherapists can't very successfully and very reliably learn bespoke methods that might be well applied to practice. So as opposed to thinking that physios can do a small amount of training and be, fully qualified as a sonographer to report on diagnostic features, please don't go that way. But there are very distinct applications that physiotherapists can learn very reliably and quite successfully. We think we're still figuring out which of those are going to be the most useful, but I think certainly in sports medicine there are clear applications for tendon measurements that could be valuable for looking at injury rates, recovery rates, and helping to design programs that are maybe a bit more bespoke for the particular athlete or the particular patient in front of you. So, as I said, a note of caution, but also a suggestion that yes, we can absolutely do this with the right training and the right support, and that this tool does have some value. The other place I see value with it, coming again from the sonography training side of it, is that it's a fantastic way to educate patients about their tendon condition. So many of the patients who I would scan have had MRIs beforehand and come, fearful about the diagnosis they've been given. So sometimes actually doing the ultrasound analysis can be really helpful. Sometimes doing the other side is a good thing. You just need to be a little bit careful. In my study, I did test both sides, and I do it clinically often with patients, and you get the odd one who comes back and says, that scan you did on the other side that showed that the other side looked just the same as the painful one. It's starting to hurt now, Karen, so watch out, okay, on that one. So you can use the condition of the other side, pain-free side, to help patients understand this is normal aging, this is like your hair being grey, this is just a picture, it's not telling us anything about how your shoulder functions. So from an educational point of view, it can be brilliant in the hands of a physiotherapist when we have time to use it as an educational explanation for patients. So I think there's great value as long as we do it with the appropriate professional regard for the skill that is there when it's been used as a diagnostic tool.
Oxygen delivery.
Just a small comment. You were talking as if it only goes for physiotherapists.
So
I think in the audience there are other people than physiotherapists. So the same rules, are they also valid for physicians, surgeons, anywhere else?
Yeah, as I said, coming as a sonographer, I'd say yes, that anyone who wants to use it as a diagnostic tool needs to train with the appropriate mentorship of someone who's an experienced sonographer. In the sonography training, I did 400 signed off shoulder scans before they considered me competent to do them, So I think there is training for whoever's involved here. Of course, yes, with a medical qualification, the diagnostic element is much more part of your work. So it's likely that you want to take on the diagnostic element if you're coming from a medical perspective. But I still think the support of a radiologist colleague or a sonographer colleague is going to be very valuable in developing those skills. And again, from a research standpoint, this has huge potential for use as well. But even for researchers, just make sure that the distinct part of the skill that you're learning, you learn it well, you test your own reliability, both once off and longitudinally, so that we are producing robust data with ultrasound.